So this is chapter 5 of the Book of Eli, and we're going to discuss tonight soft tissue injuries and burns. These are the topics that we're going to discuss. So we always review the anatomy that is appropriate for the type of injuries or sicknesses that we're going to deal with. So since tonight we're talking about soft tissue, let's go over the anatomy of the skin. And there are only 3 parts or layers that you as an EMT must be familiar with. Okay, there is the top surface of skin that you see when you talk to somebody or you see their hands or whatever. It's called the epidermis. This is the highest layer of the skin. The dermis is the middle layer, and in the dermis, there are many different things. There's blood vessel, hair follicles, nerves, sweat glands, all that is going on here in the dermis. And then we have the subcutaneous tissue, which is known as sub-Q, the letter Q. So again, the 3 layers of skin, you need to be familiar with these words: the epidermis, the dermis, and the subcutaneous tissue, or the fats. And we're going to talk more about those as we get into this. All right, big words that we've got to learn and we've got to know. So the first one is going to be, this is called a black and blue, right? In layman's terms, black and blue. So now we're going to call this a contusion. That is the word that we need to know. This is called a contusion. And there is another word that's used less called ecchymosis. Ecchymosis. So both words mean the same thing. And understand that it is small blood vessels that have burst. We should know already now that a small blood vessel is usually a capillary, and that has burst under the skin, and it is bleeding inside, but it will remedy itself and will stop bleeding. Hopefully, everybody will be okay. So that's the name here, contusion or an ecchymosis. The other type of internal bleed is going to be this. This is called a hematoma. Now, I know I've told you already that anything beginning with H-E-M-A or O or E has to do with blood. So a hematoma, this is a large amount of blood and usually swells up like a ball or a grapefruit, if you like, or a swelling. You can describe it how you want. We call it a hematoma. Okay, these colors you don't have to learn. It's just when you look at a contusion, so they go through at least 4 stages of healing. So it starts here where they're red, then they go purple, browny, bluey purple, and then yellow. So somebody with a yellow, I've done this in real life, you see a yellow bruise and you tell them, well, you didn't call for that because that's not just happened. Because you know that when it turns that color, it's already been a few days and it's already starting to heal. So the words here to know are contusion and hematoma. I want you to know these words. Closed injuries, we're going to do this on skill nights. We're going to learn more about ABCs and hypoperfusion. This is the word that we learned last class. So if there is, remember, a patient can bleed to death without 1 drop of blood being visible to you. They can bleed to death in the pelvic girdle to the hips, and you don't know what's going on inside. So always worry about hypoperfusion, low blood pressure, etc. All right, open injuries. These are obviously more fun and more that you can see and deal with. So lots of big medical words, and we got to learn them. First one is an abrasion. Abrasion means simply a scrape. Kid falls over in the yard, someone gets an injury, scrapes their knee, scrapes their arm. It doesn't matter where it is. It's called an abrasion. And it usually only involves the outer layer of skin. Any sort of bleeding from an abrasion will usually be capillary. So it oozes. It doesn't do any of the, like the venous or the arterial bleed. So abrasion is a scrape. Laceration. This is the word for a cut. A cut through the skin. Depending on how deep it is, will depend how much bleeding there is. So if there is arterial bleed, it'll be squirting and spurting all over the place. If it is a venous bleed, it will be pouring out. So again, a laceration will depend on where on the body it is and how deep the cut has actually gone through, how many layers and blood vessels. All this is stuff that we will fix and we will learn how to deal with. An avulsion, that's the most gruesome avulsion picture I could find. So that is the tearing of flesh or muscle, but it's still attached. Okay, so I think you can notice that even though that has been ripped away, that is still attached, it's hanging, it's loose. That usually it's accompanied by severe bleeding. And if it's anything more than, a fingernail, it could be pretty serious. I've seen patients die from avulsions. Puncture. All right, so now we got to think somebody got stabbed or shot. These are the two easiest ones, but there are others. But if somebody got stabbed or shot, that is a puncture. And the definition of a puncture is a wound deeper than it is wide. So it's going inwards into the body, deep. Typically stab wounds, gunshot wounds, but there are many other types of punctures, right? So if somebody is fooling around with needles and they stick a needle into themselves, right? That's a puncture. Okay, so it doesn't have to be a gunshot wound, but these are the two most seen in EMS situations. Amputation is the word people are usually familiar with, where a body part has been severed, has been removed from the rest of the body. So you need to know 5 definitions, what they are. Okay, it's just showing the bleeding side of things. An avulsion with the skin is peeled back, could be serious bleeding. Puncture, here we have some sort of needle or something that's gone through. An abrasion is just, I told you, the least scary, just a scrape, and a laceration is any type of cut. There is also another word called an incision. Usually an incision will be made with a surgical type of knife, scalpel, that would be known as an incision. But EMT school, everything just falls under laceration. Treating them, well, we're going to do this actually on a skill night, we're going to take out the equipment and show you how to do this. The blue is always very important. Do not remove an impaled object unless they block the airway. So if something is stuck in somebody's eye or arm or finger, don't remove it. It is holding the blood vessels together, and do not remove it. That gets removed in an operating room. BSI or PPE, maintain the ABCs, which we'll talk more about. Expose the wound, so if they've covered it with toilet paper or tissues, you got to get that off. Control the bleeding. And then there's different ways we're going to teach you how to control bleeding, and we're going to treat for hypoperfusion should it be necessary. So here you have some impaled objects. Remember, impaled objects fall under the penetrating injury, but they are still there. So if the object was inserted, removed, now we have a penetrating injury. If it's still there, we call it an impaled object. So question, I guess, for the audience is, would we remove this based on what we just learned? And I hope you're all thinking the same answer, that since this is not affecting airway, we would leave it in. Okay? And that would be the correct answer. So if it's not affecting the airway, leave it in. All right? Do not remove the object only if the airway is blocked. So it may be going through the cheek and then blocking the airway, causing tongue problems, swallowing problems. Get it out. Yes. But if it's not, so here we have a head, here we have an arm, and we're going to teach you how to, what we call, stabilize. You have to stabilize. We can't have that knife moving around during transport. So we're going to show you how to keep it all together, keep it nice and tight, and stabilize the object. We use some bulky dressings and then some regular roller gauze. So yeah, this is a pretty cool picture. People ask me if this killed them. I said, I don't know, but it definitely wrecked them. So there are times when you need ESU or fire department. ESU are the emergency service unit cops of the NYPD. So they are, good for this sort of thing. If you work 911, you don't get the choice. Fitney's going to come, and they're going to cut this down, and they're going to make it manageable for transport. Again, the idea is that we wouldn't remove it. Eye injuries, we do see these in the field. So again, the rule applies. Do we remove the impaled object? And the answer is no, we don't. It's not in the airway. Special rule about eyes that you must know is that when we bandage an eye, we will bandage both eyes. So keep that in mind. When we bandage one eye, we bandage both. So we will stabilize, let's say, the pin or the pencil or whatever's in there. It will be stabilized and then bandaged around both eyes. Small debris or small particles that have got into the eye are flushed utilizing this technique, and they could ask you which direction the water should flow, and the answer is medial to lateral. So from the nose, which is medial, to lateral to the outside. So these are all things that you must know, okay? All right, the word for a nosebleed is epistaxis. Okay, that is a medical word, and that is something that you've got to know. All right, epistaxis. I translate in Yiddish as episyntaxis. So nosebleeds are really annoying. I have treated countless thousands of them over the years. And they're annoying because they seem like they will never stop. So depending on how the nosebleed was attained, and there are many different reasons for getting an epistaxis. The best thing you can do, here's the treatment, BSI, keep everybody calm. Patient leans forward. I know that my grandmother and many of your grandmothers, many people from Eastern Europe would lean the head backwards. So we do not want to do that. That is bad. There is a risk of the blood dripping into the airway. So we don't want to do that. We're going to lean the patient forward, pinch the nostrils together, usually across the bridge of the nose. Some people like to use an ice pack on the nose to help. It never really worked for me. It just takes time, and they stop. They do stop. So, impaled object in the cheek. You got some nice pictures tonight. Remember, if I'm going to go the opposite, if the object in the cheek is not blocking the airway, then leave it in. Just leave it in. I've seen test questions where they ask it that way. So leave it in. Okay? If you're leaving it in, control bleeding. There may be from inside and outside. And we'll teach you the techniques of direct pressure, etc. But cheek is not a remove. Okay, cheek and airway, remove. All right, now it's going to start to get a little more complex. What happens if somebody gets stabbed or shot in the neck? So on both sides of the neck, there are very large arteries that are coming from the aorta, as I'm sure you know, and they're going up to perfuse the brain. So I'm not so worried about an impaled object, but if somebody got stabbed and then the knife or the weapon was removed, we may have a big problem. All right, so let's understand. The first problem is the possible bleeding and loss of blood. This is going to be dealt with the same no matter where the person was attacked. But now we have another problem. And these huge arteries, right? Here's the top of the aorta, called the aortic arch. And then we've got these carotid arteries that we spoke about during CPR, right? On the side of each, left and right. And we have these subclavian, left and right arteries. So these are huge arteries, and the purpose of these arteries, every time the heart beats, is to perfuse the brain. Okay? Now, somebody got stabbed, and we are now majorly concerned, not just for the bleeding. We have another concern, and that is that air will get in through the stab wound in the neck and up into one of these arteries and go up and get stuck in the brain. Now, you already, as top-notch students, know that there is no free-flowing air in the blood supply. Okay, the red blood vessels with the hemoglobin, they load up with oxygen and they unload carbon dioxide, but that is all an integral part of the red blood cell or the blood. There's no free air running around in the blood supply, and if there is, we could have a big problem called an air embolism. So I'm going to show you tonight 3 times where we're going to use this type of dressing. It has a special name, you got to know it, called an occlusive dressing. Middle of the page. Occlusive means airtight. And what you'll do is, as soon as the blood has more or less stopped bleeding out down the neck, etc., you'll apply an occlusive dressing. Now, there are occlusive dressings that you can just make out of the plastic that all your equipment comes packaged in. The good thing today is that all your equipment is disposable, pretty much, and all disposable equipment comes in sterile plastic wrapping or bags. So you can cut one of those oxygen masks, take the packaging, use the inside, and cut it to make the right size for an occlusive dressing. You would then take tape and tape it around the 4 sides and keep air from getting sucked in to the artery that is now feeding the brain. So that is the deal with a large open neck wound. Remember these words, okay? Air embolism is what we're scared, we're worried about. We are worried about, we're going to use something called an occlusive dressing. I wrote here that you could compress one carotid artery to stop the bleeding, but you understand that if you compress both, then you just killed the patient, because now there is no blood flow and no perfusion to the brain. Bandage the wound. So this is going to be difficult. You can't bandage around the neck, even though there are plenty of people that I would like to put a bandage all around their neck and tie it tight. But we're not allowed, and that's not what we do. So we're going to use various different forms of techniques, and we'll get to it. We'll talk about the bandaging and techniques. Okay, chest injuries. So this guy got shot in the chest. And we're dealing with a case where a patient was shot or stabbed in the chest or the thorax, whatever you want to call it, but it's above the diaphragm, and so it's in the thoracic cavity. Let's learn the anatomy of a lung, okay? Just the simple anatomy of the lung. Here we have the trachea. All right, here we have the right bronchi, and here we have the left bronchi, and that's the one we're going to follow. Left bronchi, and that breaks off into all these bronchioles. Remember these words? These are not new. At the end of all the bronchioles will be the alveolar sacs, or the alveoli. And that's the end of the road. That's where the air intends to go. That will be covered with pulmonary capillaries, and that will do the gas exchange between the alveoli, the pulmonary capillaries. Oxygen will be put into the blood supply, CO2 will be removed, and that will just be sent out, and they will exhale, and it will go. Great. Now, we need to know some new words about the lungs. So the lungs have a very special coating, a membrane, a sac. Again, many ways to describe it, but it is a protective coating that completely surrounds the lungs. And the name of that is called the pleura. Pleura. And I will ask you for this name. I will want to know what is the name of the sac, of the coating, of the bag, of the whatever that surrounds the lungs. And it's called the pleura. Now, the pleura has two layers. There is the innermost layer, which here has a yellow line. Okay, the innermost layer is called the visceral pleura. And then you have a space called the pleural space, or the pleural cavity, if you like. And in there, it's not this wide. They're almost touching. There is something in between them. Again, it's not really for EMT school, but it's called surfactant. And it's like a lubricant, so they don't rub against each other. So the visceral pleura is right up there touching or part of the lung. Then there's the space or the cavity. And then we have the parietal pleura, which is the black line. All right. So you see there's the blue pleural cavity, the yellow, the visceral pleura. So what happens when somebody gets shot or stabbed in the chest? What exactly is happening? So that's what we're dealing with now. We're going to deal with these big words here. Okay. So the first one is a pneumothorax. Pneumo is air. Okay. Pneumothorax, air in the thorax. Hemothorax, we know what HEMO means, right? We know that means blood. So hemothorax, blood in the thorax. And hemopneumothorax, if you wanted a tongue twister, right? Hemopneumothorax, that's the most common because that's got blood and air trapped. And the life-threatening one is going to be the tension pneumothorax, and that's the one that's going to kill people. All right, let's discuss it. Let's understand it. So here we have a normal lung, right, on this side, left. Right, we have an injury. So what happened? So the patient got stabbed, and really what got stabbed was the parietal pleura. Now has a hole in it. So the chest wall has a hole in it. The parietal pleura has a hole in it. Guess what happens? Air is going to rush in because now there's a hole in the chest that isn't supposed to be there. There is a hole in the parietal pleura that isn't supposed to be there. So air is rushing in from here because we know that gases move from area of high concentration to low. So there's no air supposed to be in here. There's loads of air out here. And usually it comes in through the trachea and the bronchi, and it goes through, right, proper channels. Here, it's just rushing in. So we got a problem. Houston, we got a problem. And as more and more air is pouring in between the parietal and the visceral pleura, the lung begins to collapse. And this is what's known in layman's terms as a collapsed lung. We call it a pneumothorax. Here would be a hemothorax where blood is pouring in. Typically, it will be a pneumothorax, which seem to be the most common. So that's what we see in the field. Again, this would cause a collapsed lung, and a pleural effusion means that there is fluid in the pleural space that shouldn't be there. Okay, here's the normal pleural space. You can't even notice that it exists. So my question is, patient A, patient B, are they going to die? Are these patients going to die? And the answer is no, not right now. Why are they not going to die? Well, they can breathe on one lung for a while. It may be difficult. It may not be the most pleasant type of breathing, but they can breathe on one lung. So right now, these patients go quickly to a 911 receiving, a trauma center, and they will have a procedure done where a tube is fed into the bad lung, called a chest tube, and air is allowed, air, also blood, is allowed to escape. And that's really the treatment. They don't often go for surgery, but sometimes they do go for more than just the chest tube, depending on the injuries, et cetera, et cetera. This is not really part of EMT curriculum, but I think it's very important that you know what this is, because every so often one will crop up. It's called a spontaneous pneumothorax, and it happens typically to males who are tall, skinny, in their 20s, early 20s. I've seen a few of these, and it's pretty cool when you can nail the diagnosis. So, tall, skinny, in their 20s, they had no bang, no accident, no nothing that they can say this is what caused a problem for me. But they do have difficulty breathing. It happens quite suddenly. And it's basically a pneumothorax, but this time the lung leaks air into the pleural space. So you end up with exactly the same problem. We've got air in the pleural space that shouldn't be there, right? But this one isn't from trauma. The lung collapses, and the same idea, chest tube insertion, and usually they are fixed, and after a little bit of rest, they're usually okay. So that's called a spontaneous pneumothorax. All right, let's go back to our pneumo or hemothorax. Let's talk about what's going on. So this is an occlusive dressing, right? We've seen it once with the neck. Now we're going to use it here. And as you see, here's the hole. And we took some sort of plastic, some non-porous material. We taped around. And we made an occlusive dressing, okay? It's okay if you want to leave one corner open to allow a little air to escape. Sometimes if you do all four and you make it too tight, they have a problem getting air out, and sometimes their breathing can get worse even though you've fixed it. You stopped air from rushing in. So it is good sometimes to allow air to exit. but that's the whole deal with the 4 sides or 3 sides. So you can leave a small corner open. The biggest concern is that if you don't stop the air from getting in, you don't stop it, okay? They got the wound, the blood is pouring in, or the air in the blood, whatever it is, it's the same thing. So what happens is that the bad lung is going to get pushed because it's not in its regular place, right? There's a pressure coming in, and it's getting pushed up against, what's this guy called in the middle? This is the heart. So it's getting pushed against the heart. The heart is getting pushed against the good lung, and there's no room. And this is known as a tension pneumothorax, and this is what kills people from stabbing gunshots that are in the chest.
How can you tell?
So on examination, you will see that the patient will have no lung sounds on one side, and your job is to stop the air from getting inside and to put the occlusive dressing. And then I'm going to show you on another next slide or so, I'm going to show you how you know that it's changed from a pneumothorax to a tension pneumothorax. I'm going to show you. Let's just talk about this one. It's called pericardial tamponade. This is where the heart bleeds into its own sac. So we spoke about some different sacs that we found around the body. During anatomy, they should have mentioned for you that the abdominal organs are surrounded by a sac called the peritoneum. The lungs are surrounded by a sac called the pleura, and the heart is surrounded by a sac called the pericardium. So these are some, we're going to do also a sac around the brain and spinal cord on another night. But you got to know these. You got to know these. So the heart muscle itself is the myocardium. And then this line here, the black line, or the sac, this is called the pericardium. And for whatever reason, usually it's trauma, but the heart now has a gash, it has a laceration, whatever it got, but now it's bleeding out. And again, the first place it's going to bleed out into is its own protective sac called the pericardium. This is known as pericardial tamponade. And the problem here is that the ventricles don't have room to do a proper systole and diastole. So what happens is that the systolic number will get closer and closer to the diastolic number because the squeeze is almost the same as the relaxation phase. We know that the heart needs both. We need the heart to relax so that the heart will fill and get new blood on the left side. The right side will get the used blood, right? And then the squeeze, the systole, is where the heart now puts out that blood, whether it's to the lungs or up into the aorta to the whole body. When there's no room to do the squeeze, what we find is that the systolic and diastolic blood pressures approach each other. And here's just a simple, like, you know, this could be a normal blood pressure, 110/68. If you minus it, you get 42. But what happens if you have 78/68? And now you do the minus and you're left with 10. That is called decreasing pulse pressure. And it's found, for your learning right now, it's found in pericardial tamponade. Something here called Beck's triad. Again, it's not in the EMT curriculum. It's good to know. Good to know. Engorged jugular veins. So there are veins on either side of the neck. And if you can see them when a person is semi-Fowler's, that's distended or engorged, okay? Large jugular veins. I got a picture coming up. Narrowing pulse pressure, which is this, where it wouldn't be 40 or 30 between them, but 10 or 5, okay? And muffled heart sounds, that's when you actually listen to the heart and it doesn't sound right. So that's called Beck's triad, 3 things. You don't need to remember that. Remember decreasing pulse pressure and pericardial tamponade. Okay, this would be JVD. We call this JVD. Jugular venous distension. And this can come, it can come from a hemopneumothorax. It can also come from cardiac tamponade. So here's the answer to your question. How do we know if they went into a tension pneumothorax? Okay. And the answer is that the trachea will no longer be midline. It will be deviated to one side. So here we have air flying in, bad lung is collapsed. Now it's pushing up against the heart, pushing up against the good lung, and it's forcing the trachea to not be midline where you would expect it, but now it's going off to the side. This is a late sign that your patient has a tension pneumothorax. You should have paramedics, and paramedics will take a needle and get the air out of the lung here or here, and just, it will save their life. Okay, but you have to recognize it. The pneumothorax has like a nickname. It's called a sucking chest wound. And the reason for that is because you can actually hear the air being sucked in to the chest. Okay, you can hear it sucking in. And eventually, if there's tension, it will show this TD or tracheal deviation. This is JVD. Another injury in the chest.
I'm sorry, Ribelli. Again, I'm the JVD proves to you what?
Cardiac tamponade.
Okay, got it. Okay.
Another injury to the chest or the chest wall is known as a flail chest or a flail segment. So if you see the picture, you can see that there are 3 ribs broken in 2 or more places. All right, and that's really the definition. This segment of rib cage will act the opposite to the rest of the rib cage because it's completely not attached. So broken ribs on their own, when someone gets a crack or a broken rib, they're very, very painful. This is intolerable. Okay. Give them oxygen, get medics, medics will give them pain meds and get them to a hospital quick. So this is only from trauma. The interesting thing is that as the patient is breathing in or inspiration, so the chest wall won't be moving out, the flail segment will be doing the opposite. That is known, and you gotta know this word, paradoxical respiration. That means that the segment is moving in the opposite direction to the rest of the chest, to the rest of the rib cage. And you'll just see that. And it's known as a flail chest. If this happens mainly in sports, but it's important to know. Okay, it's important to know. What's going on here is that this kid is the pitcher, and he sent a fastball to the batter, and the guy hit the ball and whacked it right into the pitcher's chest. This happens occasionally in professional sports. It has been documented and seen. The person that gets hit can drop in cardiac arrest. And the good news is that if the coach or the medical team has a defibrillator, they can usually restore normal activity to the heart. So it can happen in different sports. It can happen with a fist or a punch to the chest. It's known as commotio cordis. And again, it can change a normal heart rhythm into a dead one, unless you have a defibrillator that you can fix the problem with.
What's the difference between the two?
I only spoke about one.
Uh-huh. Okay.
Gunshot wounds, very little on the EMT curriculum about it. The entry will usually be small. The exit wound will usually be larger. All right, remember to look for both. Look for both if you have a gunshot patient. There's a lot of damage done inside, which is shown here, but you don't really need to get into it. All right, great word. Evisceration. Evisceration. So very important word, and you got to know it. Basically, evisceration means something that's supposed to be on the inside is now on the outside. That's really the definition. Okay, start off with make sure you keep them alive. ABCs, make sure bleeding's been dealt with, oxygen, airway, stuff like that. Now, do not replace the organs, right? So don't think that you know that you're going to shove that back in with your finger, okay? Somebody went to school for 12 years to learn where to put all that, okay? So we're not going to put that back. What are we going to do? Well, we're going to cover the organs with a moistened sterile dressing. Now, we do carry a very large sterile dressing called an abdominal pad, and that's what you're going to use. Why moistened? Because the abdominal organs live in a moist environment. So we don't want anything dry that's going to stick to that and not be able to be removed without causing more damage. So you will be carrying sterile water part of your 800, you'll have it. You can moisten a dressing large and put it over. On top of that, you're gonna put a dry dressing. And guess what? The last one here is the third occlusive dressing. You're gonna use the packaging that your abdominal pad came in. We will show these to you on skill nights and keep it secured, tape it down all sides. This is to prevent infection. This is to prevent infection. So you really want to get this done quickly. Get a moistened dressing, a dry dressing, and then occlusive on top.
How does such an injury like that happen?
How? Slice, stab. Amputations. Okay, with an amputation, I'm not really using the slide. I'm just gonna tell you, and then you'll see that it says this on the slide. I'm gonna make an assumption that you have 2 Ziploc bags and an unlimited supply of ice. Okay, this is ice. These are ice packs, cold packs that you keep in the ambulance. They're not very good. They're good for about 10 to 20 seconds. After that, not very good. They don't last. But for this slide, we're going to assume we have 2 plastic Ziploc bags and an unlimited supply of ice. Okay, here's what you do. You take the ice and you put it into one of the Ziploc bags. Filled, half filled, nobody cares. Okay? Next, you take the body part that was amputated and you place it in the second Ziploc bag. You can, if you want, you can wrap the body part in a moistened dressing. That's fine too. But the main point is that you put it in a second plastic bag. You then take the second plastic bag that has the body part in it, and place the whole bag into the first bag with the ice. What is the point? That the body part never comes in contact with the ice. Make sure you transport the body part to the same hospital as the patient who has lost it. In New York City, we have a replantation center, which is in Bellevue Hospital. That is where we go if we need a good tailor to try to get something replanted. That's it. So again, bag of ice, body part in a separate bag, that bag in the bag of ice. And that's how you'll transport. Abdominal injuries, not going into all this, make sure you know your 4 quadrants and the main organs and where they are. The liver and the gallbladder is in the, anybody know which quadrant this is?
Right
The
up.
right upper.
Good. Right upper quadrant. The appendix is down here in the right lower. On the left side, we have the stomach spleen in the left upper. That's really it. These are the things that you really need to know. Oh, here's the peritoneal cavity. Okay, so the abdominal cavity is also known as the peritoneal cavity because the peritoneum is the lining of most of these organs. In New York, we have things called trauma centers. In Brooklyn, there are 3. There's now more because Methodist and Maimonides became trauma centers. Queens, Staten Island, Manhattan, and the Bronx. So every neighborhood has trauma centers. Burns. Burns are injuries that EMTs see quite regularly. So there's a lot to learn about burns. Okay, first thing is how we classify the burn. That's the first thing. And we have 3 names: 1st degree, 2nd degree, and 3rd degree, where 1st degree is the least serious, 3rd degree is the worst. But we've got to learn the real names. So the real name for a 1st degree burn is a superficial burn. Superficial. And the way to know that your patient has 1st degree burns is red skin. Red skin. So the example I always give is a sunburn. Somebody goes out in the boiling heat and doesn't cover up properly. They get all red, arms, face, ears, neck, wherever it is. Those are 1st degree burns. But you can also get 1st degree burns by touching the barbecue grill for a split second, or tiny drop of boiling water falls on you. So we're not talking about how the burn was afflicted or how the patient got the burn. Right now, we just want to classify the burn. So 1st degree burn classified as redness on the skin. Simple. 2nd degree burn. 2nd degree burn known as a partial thickness burn. And this is characterized by blisters. Blisters, big, white, ugly blisters on the skin. Now you may get then the blisters may have popped, but they were still blisters, and that's still a 2nd degree burn. You don't pop them ever. Okay? We'll talk about treatment soon, but let's understand 1st degree, redness. Nothing else. 2nd degree, redness and blisters. Remember, you'll always have every lower degree accompanying the one that you're most concerned about. 3rd degree, this looks like a piece of steak that's been left on the grill. And it is now just turned black. If you continue to cook it more, it may turn white as it starts to burn up. This is the most serious type of burn. This is the type of burn you don't see every day. You need actual fire to burn all the way 3rd degree. So it burns.
I have one. I could show the item. I have one.
All right. So again, superficial will just be redness. Partial thickness will be blistering, and full thickness or 3rd degree will be down into the muscle. Maybe you'll see bone, depending on how long they were exposed. All right, now we classified the burns. So you're coming in, you have a 18-year-old male with 2nd degree burns, secondary to whatever it was. But now we got to know how much of the body was burned. So we know what it was, we know who it is, but now we need to know how much. So you can draw this on exams, you know, you can draw a stick figure. And this is going to be called the rule of nines for the adult. This is how we calculate it. So the entire head, front, back, sides, the entire head is worth 9%. All these are percentages and they go in nines. Each arm is worth 9% of the body. Right? So if somebody got burned, the entire head and the right arm, so then you will know they got 18% burn. Very simple, right? In EMT school, all the answers will be in the 9 times table. They'll all be a number that works with 9. Then we have the thorax and the back. So the thorax till the diaphragm, that includes the neck, right? And the back will each be 9%. The abdomen has a front, an anterior, and a posterior. All right, we're looking for 11 times 9. 11 times 9 will give us 99%. So far, we've got 4, 5, 6, 7. All right, now we go to the legs. Each leg has an anterior and a posterior. So each leg will have 2 9%, front and back, left and right, however you want to divide it, doesn't matter. So if we count up the 9s, we have 4, 8, 9, 10, 11. We have 11 9s. 11 times 9 is 99. And of course, the 1%. This is known as the bris. This is known as the 1%. So you got to know this. You've got to be able to read a question where they tell you various body parts have been burned. And you'll have to calculate how much of the patient was burned.
I mean, the answer is always going to be 9s aside for that one specific area.
They won't include that. And the answers will be either 9, 18, 27, 36.
Right.
Yes.
Right.
I don't use this, but it's just showing you, for example, that the 9% is 4.5 front, 4.5 back, right? I told you it's the entire head. This is an anterior and a posterior. So I don't really use it. It gets too complex. Okay. There are 4 places that are called critical areas. 4 places. You have to remember these. Hands, not arms. Hands, feet, not legs. Face, and genitals, the 1%. These are called critical areas. Why? Because it would be difficult to lead a productive life with burns to the hands, face, feet, and genitals. So these are critical areas, and you're going to see how we're going to upgrade these burns because of the location. So it's going to be the amount and the location. I'll show you. All right. Why does it matter what type of burn you're dealing with? Why does it matter? Oh, very simple. because critical burns need to go to a burn center. All right. Moderate burns don't have to go to a burn center, but you could if you want to. Okay. Now, there are not many burn centers in New York City. Brooklyn does not have a burn center. Just putting it out there. So if you're in Brooklyn South, which is like Borough Park and Bensonhurst and all that sort of area, you would go to Staten Island. If you're in Brooklyn North, which would be like Red Hook, Greenpoint, Williamsburg, you will go to Cornell in the city. And if you're in Brooklyn Central, you can choose. You can go to either because they're pretty much similar distance. Lately, I've been very happy with Cornell, and I've taken quite a few of my burn patients there that needed it. So let's just look at the difference. So for a first degree burn to be critical, we're looking at 75%. And it's rare that it happens. Why? Well, you'd have to like go out, lay on the beach in nothing but a Speedo, couple hours on the back, couple hours on the front, then realize that you should have worn sunblock 600 and you didn't wear any, and now you're red as a lobster, and now you've got over 75% burns, and yeah, you got the critical badge. So it's rare, doesn't usually happen. Second degree burns, so we're looking at a BSA, body surface area, of more than 30%. 30%. So think about your nines. 9, 18, 27. So it'd have to be 3 areas that were completely burned to be 30%. Or here are your 4 famous places, right? Face, hands, feet, and genitals, right? One of those. Or obviously burns involving the respiratory tract, anything to do with breathing. And this is a great word, circumferential. Circumferential means around and around, all the way around. So if there's a body part and it's just one body part, let's say the arm, left arm, and it goes all the way around the arm, but we're no way near 30%, you can still go to burn center because circumferential burn. Third degree burns, well,
What would be a burn involving the respiratory tract?
so that I'm going to let me hold that thought. I'll get to it. So third degree burns 10%. I use 9. So one body part, 9% body part is burned. That's it. They're critical if it's third degree. Obviously, the hands, face, feet, and genitals, same thing. Respiratory tract and circumferential. So all these would actually go to burn centers. And I will get to respiratory in a minute. All right, how do we treat burns? There is one treatment for burns, okay? And that is cool running water. End of. I don't want to hear what your grandmother told you when she came out of Russia or Hungary or wherever it was. Cool running water. That is the EMS or at home or whatever, that is the treatment for burns. Remove clothing that is close to the burn. If it has stuck to the skin, do not rip it off. Try to get that jewelry off if it's near the burn area. And then there's this whole thing with, do you cover with moist dressings or dry dressings? So always worried about the patient getting cold and maybe they're going into shock. So this is how it works. If it's less than 10% BSA, which is body surface area, use moist dressings. If it's more than 10%, use dry dressing. So again, I use 9% as my cutoff for everything because 10 doesn't really fit with the way that we are making calculations. Bandage doesn't need to be bandaged tight, needs to be bandaged sort of loosely, just to keep infection out. And do not break blisters. If there are blisters, do not break them. But the only treatment is running water. Now, depending on the size of the patient and depending on the size of the burn, okay, running water could be in a kitchen sink, bathroom sink, or it may require a shower. So there is no right answer to how you're getting it, but cool running water needs to be applied. There are different types of burns. Electrical burns are, you can't get an electrical burn, by the way, from 110. That would be serious. But electrical burns, real electrical burns, 220 and up, they are really bad. That can be an entry and an exit wound, just like a gunshot. So, and I want to get to this in a minute. Radiation burns, well, you've got to keep away and you need special protection. I don't know if you should be going in there. Chemical burns, very interesting. You want to irrigate for at least 20 minutes. Make sure you don't touch the chemical. Sometimes it's a dry chemical, all right? And that dry chemical needs to be brushed off of the patient's skin. Never try to figure out how to neutralize the chemical. Oh, yeah, I think it's an acid, so yeah, I'll pour some milk on it because that's the opposite. No, don't try to do that. Don't make a chemistry experiment out of your patient, okay? Cool running water, at least for 20 minutes. Okay, so this is an electrical burn. These patients that electricity blows up in their face, what happens is that they will breathe in this super boiling hot air, and it will burn the inside of the airway, and there can be respiratory issues. So this is to answer how you get respiratory problems from burns. They're usually from electrical burns. I have had patients with these, and they can be pretty bad. It's good to have a medic there who may just decide to put the patient out and put a tube down their throat, intubate, so that the patient can make it and breathe all the way to the hospital. So that is what it means by respiratory tract. So, yeah, I'm just going to tell you this again. We don't have a burn center in Brooklyn or Queens. All right, you can go to Manhattan, which would be Harlem Hospital, or Cornell, which is the closest one for me. In the Bronx, you have Jacobi and Staten Island North. So depending on where you are in the city is which of these you will use. Vital signs. We gave you an introductory demo into vital signs the other night. everybody should have a watch with a second hand in class. We don't like digital numbers in EMS. Could be that that's a very old and antiquated thing, but everybody that does this has a second hand on their watch, because it's easier to look at the watch and say, oh, second hand's on the 12, and I need to know when the second hand gets to the 6. You're not counting anything. You don't have to remember any particular numbers. Stethoscope, blood pressure cuff, you should be bringing now to every skill lab, and we have one tomorrow night. So these are some of the vital signs, and again, we're going to work on these. We look at the skin, we look for CTC, color, temperature, and condition. Pulse is rate, rhythm, and quality. Eyes should be equal, random, reactive to light. Respirations will be rate and quality. Mental status, I'm going to talk about in a minute. AVPU. And blood pressure, we get 2 numbers known as systole and diastole, or systolic and diastolic. So I'm pretty sure that we went through all this stuff. I'm just going to go through AVPU in case that wasn't clear. One of the most important vital signs of every patient is what is their mental status. It's so important. Had a 15-year-old girl hit by a car the other week, smacked her head, completely destroyed the windshield with her head. And I asked her, she was in school uniform, so I asked her if she'd been to school today. And she had no idea. She didn't know what the day of the week was. She knew her name, but she didn't know who her mom was at the beginning. These are all the things that we look for with mental status. So you have to really understand that this is every single patient, okay? So sometimes you ask the question, let's say the husband is the patient, and you say, so, sir, what is your name? And then the wife is in the kitchen, like, his name's Bob. And you're like, okay, so that, right, completely ruined the whole experience there for me. But you've got to like say, okay, but I need the patient to answer the questions, please. And very often, you know, you get into this where the mom or the father or the brother, someone's answering for you, and these are not difficult questions, but they're very, very important. So we use this mnemonic called AVPU. AVPU stands for alert, voice, pain, and then unresponsive. AVPU. Let me show you how you do this. To be alert, to get an A, you got to get 3 out of 3. And you got to answer all the questions correct. So we want one question that involves person. So you can say, what's your name? It's not the best question because you don't know if they're telling you the truth. So the best question is, who is that? Someone else in the apartment? Who's that? Do you know that person? Question 2 is place. Where are we? Where are we? Are we in your apartment? Are we in the back of an ambulance? Are we in Yankee Stadium? Where are we? All right. So this is place. And the third question is anything to do with time. You don't ask them what is the time and never ask what is the date, because high functioning CEOs of companies don't necessarily know the date on any given day. So you ask, what day of the week is it? Or what time of year is it? What's the season? What holiday are we near? That's all acceptable, and that is all fine for time. So those are the questions: person, place, and time. I like to ask if you have people around, like who's there is better than who are you. Sometimes I ask both. Place is easy. Where are we right now? And time, anything to do with season, holidays. You can try days of the week, you can try months. Sometimes, it gets complex. So to be an alert patient, you need to answer all three. Okay. If I ask the patient, this is something I see a lot. Oh, what's bothering you? And the patient says, yeah, I got a stomach ache. Okay, they're not necessarily alert. They know they have a bellyache, but they didn't answer the three questions. They didn't even answer one of them. So I see this a lot. Oh, but the patient told me that they had a bellyache. No, it's not one of the questions. Okay, so it's fine to ask more questions. What's bothering you? What hurts? We're going to teach you to ask that anyway. But for A to be alert, it's not the same alert that you're thinking about, or let's say even a teacher-student situation, right? Yeah, students alert. There's someone listening to what I'm saying. Not enough. Alert, three questions. Voice is if they respond to your verbal stimuli. So if you say, hey, buddy, what's up? What's going on? And they groan or they moan or they grunt or they hick you, those are all V's. Okay, they don't have to speak. So V is a very big category. All right, any sort of reaction to your stimuli. They're also a V if they get any of the three A questions wrong. They drop into the V box. So they can go from getting two questions right, one wrong, to not speaking, but they open their eyes when you talk to them. Or they try to get rid of you, or they groan or moan. All you've got to do is talk, and then you see if they're a V. P is pain. P is now, okay, they didn't get the A, they didn't get the three questions right. They didn't respond to me when I spoke, so now we go to pain. There's a way to inflict pain. The way that we usually use these days is by pinching above the shoulders, pinch the skin. That is, they can also pinch the tragus of the ear, which is the lower hanging part of the ear. All you need is for them to respond. If they open their eyes, if they move your arm away, stuff like that, that's a P, and now they are in the pain box. U is anybody that does not respond in any way to AVPU. Okay, so if you haven't spoken to them and you haven't attempted to hurt them, they can't be unresponsive. No one's unresponsive until you check. So that is the AVPU scale, and that is how you do it. sample. I don't know if anyone did this with you yet, but these are 6 questions that we ask every single patient that we can talk to. Okay, obviously, if they're unresponsive, you can't do a sample. It's known as sample history. All right, and you got to know this. Every one of these letters. S, signs and symptoms. What's bothering you? What else is bothering you? Talk to me. A, what are you allergic to? I want to know about food. I want to know about medications. I want to know about people. I want to know who you're allergic to and why and what. M, what medications do you take? What medications are you supposed to take? All right, sometimes a better question with our community. What medications were you prescribed rather than what medications do you take? P, past medical history. Okay, you had pneumonia, you had a stent in your heart, you had open heart surgery, I don't know, whatever they had, we need to know. L was last thing they ate or drank before the 911 call, right? Last oral intake, L. And E, I use this for what is going on in your life emotionally, socially, okay? Not how did you get hurt? Because when we use this, we use it together with another set of questions, which are going to deal with that. So E is going to be emotional events. Are you stressed out? Are you having stress from work? Are you having stress at home? Are the kids driving you nuts? Whatever it might be, these are all the E things.